Hello, my name is Doreen Grasso, and I am the Education and Program Manager at the Brain Injury Association of Rhode Island. And we're happy to bring you TBI and the EMS Worker. So let's get started. The Brain Injury Association is the only nonprofit solely dedicated to brain injury. And we like to increase the awareness of brain injury and its consequences, providing education and preventing brain injury, enhancing the life of those affected by brain injury. Today's topics include: what do we know about concussions? What are the national and state trends? How does it affect different populations? Males, females, seniors, domestic violence victims, criminal justice system involved people, mental health, homeless population, and concussed youth. We'll go over a little bit of Brain Injury 101 facts and how brain injury may affect your experiences and how reporting really helps. And what role the Brain Injury Association, or BIARI, plays in helping survivors navigate the systems here in Rhode Island. Let's get started. According to the CDC, 223,000 TBI-related hospitalizations occur every year from 2019. And that's increased to 63,362 and about 176 Americans who actually died in TBI-related injuries each day, up from 61,000 in 2019. TBI-related emergency department visits and deaths in 2014 were approximately 2.87 million, and those were only the ones that we have recorded through emergency departments. We easily think that number can be doubled for the people who did not go to emergency departments. There are only about 278 certified brain injury specialists in the US, primarily serving adults, and very few here in Rhode Island, for which we have a gap in services. The average annual number of traumatic brain injury related deaths, according to the CDC in 2018 and 19, unfortunately, suicide accounted for 35.5% of TBI related deaths, and they were really higher among older adults, surprisingly enough to me. Unintentional falls accounted for almost 30%, the highest being over 75 years old, for obvious reasons, a lot of slip and falls and lack of reaction time. Unintentional motor vehicles were approximately 17%. Those are a little higher among the 15 to 24 range and 25 to 34 range. And birth to 17 years, the most common mechanism of injury for TBI-related deaths were due to motor vehicle crashes. Let's look at Rhode Island. There are over 14,000 concussions per year that are registered through the emergency departments. So likewise, that is going to be a lot more for ones that aren't counted. So that's 38 a day and about 1.5 per hour, comparing to 285 per hour and 4.8 per minute nationally through this, according to the CDC. TBI, most commonly, TBIs happen from falls, fire-related injuries, motor vehicle crashes, assaults. I work a lot with the schools as well, so I added sports and activities for students and children as well. So the CDC says that TBI affects the lives of people of all ages, but there are some groups that are actually at greater risk of dying from a TBI or experiencing long-term health effects after an injury. They are racial and ethnic minorities, military service members and veterans, homelessness, people in correctional and detention facilities, survivors of intimate partner violence, people who live in rural areas because they have less access, and then people with lower incomes or without health insurance. How might TBI affect various subgroups of the population in which you might interact or with whom you might interact? Males and females, seniors, justice-involved persons, domestic violence, veterans, mental health issues, homeless and marginally housed persons, youth and students. Interestingly enough, when you compare male and female, it looks like here between unintentional motor vehicle crashes, unintentional falls, suicide, and homicide, males have a higher incidence of TBI compared to females. When we look at older adults, TBI may be missed, especially in an EMS first responder situation. You might have to stop the bleeding, or if it's an accident, it might not be the first thing you look for, but I know that it's also in your protocols. So older adults tend to be more likely to be hospitalized and die from a TBI. They may be misdiagnosed. Other symptoms may be related in coexist along with the TBI. Healthcare providers should check for signs of TBI if an older adult has fallen or has been in a crash. Also, their brain tends to shrink. So all those, even though the brain is gelatinous and it's close to the meninges and the outer layer, there's some space there. So a lot of things can happen with some tearing and bleeding. This is especially important among older adults who are taking blood thinners, anticoagulants, antiplatelets, and they have an increased risk for brain bleeding. So when you talk about older adults as well, we're much more active, 55 to 64, but over 65 too, definitely want to get things checked out. I thought this was quite interesting. I was part of a webinar on justice-involved youth and adults with brain injury. And when you look at some of the statistics, they're pretty staggering. Justice-involved traumatic brain injury, when you look here and compare the incarcerated population with the general population, it's high with history of substance abuse, mental illness, suicide, childhood trauma, adult trauma, school suspension. And anyone who's had a history, even in the younger years of traumatic brain injury, 40% of incarcerated juveniles and 60+% of adults incarcerated have reported, when they did studies, have reported some kind of incidents that would be considered a traumatic brain injury. So it'd be really interesting to see, what we could do even on the juvenile level to make sure that they aren't end up being the same people, the same statistic as adults incarcerated. When we look at domestic violence, research indicates that over 60% of women, with estimates as high as 90%, who experience intimate partner violence, sustain an injury to the face or head, including strangulation. So unfortunately, brain injury, whether it be acquired brain injury or traumatic brain injury, is often found with people victims of domestic violence. So what we're really trying to do in the state of Rhode Island, and I've been working with the Rhode Island Coalition Against Domestic Violence, is really trying to look at those screening questions that happen when they get the calls with people in a domestic violence situation. So 1 in 3 women experience intimate partner violence, 1 in 6 men, 92% of intimate partner violence survivors may also suffer from a brain injury. And also they might be suffering from multiple brain injuries. So these are just a couple of things. There's the Ohio Domestic Violence Network, and this between the chat and the helps, we're trying to find ways to integrate these questions into the intake forms that are happening for the Coalition of Domestic Violence. But you might want to take a look at them as well. There's something that you can maybe use in your protocol when you're asking victims about their situation and maybe treating them. Another group are veterans. So veterans, TBI, and mental health. There's been a lot of studies there. The brain affects how you think and feel and how you act. So a TBI can affect your physical actions, thinking abilities, and behaviors. This could range from mild to severe, and it may increase mental health conditions such as anxiety and depression and sleeping problems, which often happen with people with PTSD, and it's happened a lot with veterans. They could get a TBI from being around IEDs and explosive devices, or just combat itself, or training. So when you look at this, these are the co-occurring symptoms of post-traumatic stress and traumatic brain injury. So you can see that fatigue, insomnia, depression, irritability, anxiety can actually overlap. Those are overlapping symptoms. So it could be kind of a double whammy. You could have someone who is a veteran who has PTSD and TBI, and so these are going to be exacerbated. Mental health disorders also can be exacerbated by a traumatic brain injury. Studies reveal that approximately 1 in 5 individuals may experience mental health symptoms up to 6 months after having a mild traumatic brain injury or concussion. Contrary to common assumptions, mild head injuries can cause long-term effects. These findings suggest that follow-up care after head injury, or even for mild cases, is crucial. And this is where we have a little bit of a gap as well. So if people just go to the doctor, they say, okay, you know, a couple weeks later, I'm fine. We really want to try to get people to get into a little bit longer term or revisit their doctors. So there's a study as part of the NIH-funded Track TBI initiative. It's a long-term study of patients treated in emergency departments. It's, you know, overturning many of our long-held beliefs about traumatic brain injury, particularly what happens with patients after they leave the emergency department. So that we're trying to put more concentration on keeping track of those people after they leave the emergency department. The Canadian Institute of Health Research systematic review, they did a big meta-analysis, and they found a lifetime prevalence of severity of any severity of TBI to be 53%, and lifetime prevalence of moderate or severe to be 22.5. TBI was consistently associated with poorer self-reported physical and mental health, higher suicidality and ideation and suicide risk, memory concerns, increased health service, and criminal justice involvement. So I worked a lot with the schools here in Rhode Island. I manage everything that's happening with the baseline testing in Rhode Island, and I talk with the athletic trainers and school nurses. I work with teachers. I work with athletes. You know, concussions among youth have been in the spotlight. It's interesting when you talk about impact sports, because that seems to be the main focus. It's 40% of all of the concussions that happen with students. There's another 30% that happen in activities, but not impact activities. And then there's another 30% that happen with just slip and falls and car accidents and stuff like that. So, you know, even though the focus is on impact sports, we at the Brain Injury Association have really made sure that we're being inclusive of the non-impact sports injuries that are happening in the state. In 2019, I look at the statistic, about 15% of all US high school students self-reported one or more sports related or recreation related concussions. So, you know, I've also heard 1 in 5. So that's a little bit fluid, that percentage, but it's pretty high. So when you look at college here, interestingly enough, you know, people think about football and soccer and hockey. The CDC just added cheerleading to the list of people that get concussions, you know, because a lot of times the cheerleaders are practicing on gym floors or out in the hallway. You know, I've heard of equestrian concussions. So it can happen in just about any sport. But this gives you an idea, you know, the football, ice hockey, lacrosse, soccer, some of those contact sports that happen. And then there's also what happens with students reporting 1 concussion over here on the right-hand side, and then in blue, ones that have more than 1 concussion. So things do differ between females in concussion and males in concussion. They say that females concuss at a much lower G-force. You know, I think they think it's related to neck strength. And they also tend to report concussions more than males. So there is a law in every state, including Rhode Island, that is a going back to sports. It's called return to play. And everyone needs to follow these steps. So what happens is if there's an athlete that's on the field and a coach or someone, expects, or an athletic director suspects a concussion, they get pulled off and they cannot return unless they have a doctor's authorization to return. When they do return to play, they have to follow this 6-step process. And it's based upon the World Concussion Consensus Statement, which gets updated each year, every few years. They haven't met since, due to COVID. I think they're meeting the end of this year in Holland. Number one is you get back to regular exercise. You go back to school even prior to the exercise, but you go back, you get checked after each specific step here on this list. So you go back to regular exercise and activities, and then you see if that exacerbates any symptoms. So anytime symptoms, you want to push up to, but not through these thresholds. So if something happens, you exacerbate symptoms, you go back to the previous step. Then there's light aerobics, moderate activity, heavy non-contact activity, practice and full contact, and then back to competition. So what we really want to do is avoid second impact syndrome in all sports. So you don't want to get a concussion while you're still recovering from the first concussion. And that's what we're trying to do at all costs, because that's when it could be more damaging and more long lasting. So I know you're familiar with this, the Glasgow Coma Scale, looking at the various scale for eye response, verbal response, and motor response, but that's also used in youth sports with athletic trainers. And I'm just going to show you right here. So the athletic trainers, most of them in the state use a SCAT-5, a concussion tool. It's pretty comprehensive. So they take observable signs and they do some memory assessments. They do the Glasgow scale. They do a cervical spine assessment. And then they start looking at the background, and then they start doing symptom evaluation. So what's really important too is if you find that you're on a call and you get called to an athletic field, if there's an athletic trainer on board, it's not required in the state. So you might find that there isn't one, but if there is one, they may have all this information that they can share with you that might help expedite your processing. Again, this is the second page of it. It's lengthy, it's 4 pages. Cognitive screenings, immediate memory, counting digits backwards, neurological screening, and then their decision. So you can take this and you can, I'm going to move my face right here because I seem to be blocking some things. Here we go. So when you call to that event, that athletic trainer can give you this information that you can use for your assessment. But let's not forget the other 60%. Move myself back over here. Let's not remember the other 60% of students and youth that either are getting into slip and fall accidents, bike accidents, car accidents. And this one down here in the corner where there was some, I put it there because it's just there's always some silly TikTok thing that students are and youth are trying. This one was people purposely running in and whacking their head on a door jamb. I guess it was one of the TikTok fads at the time. I hope it's gone. So there was a survey just prior to COVID. There was a survey done from the Rhode Island Department of Health through the Rhode Island school nurses. With only a 50% response rate, there were 769 documented concussions that school year. So if we extrapolate that information, we can easily say it's over 1,000, because you double it, or that's only 50% of the nurses. And those are only the ones that actually get reported to the nurse. So we work with nurses a lot because they are kind of like the front lines of people in the classroom. I mean, in the schools, and then trickles down to the classroom. So we want to try to make sure that we get some better reporting there. These are the most common symptoms I think of, with students. This is from the CDC Heads Up program, which is about sports. Kids will complain about headache, fatigue, but this other one here, I have to say, even though it's very vague, they say, I just don't feel right. So that's very valid, even though it's vague, because they're the person that has the concussion, but they know that they don't feel right. And also, I really encourage when I speak to parents and other teams and teachers, you know this student best, you know, their friends, their family, their teachers. If they seem a little off, question that. Because you're the one that noticed, not necessarily a doctor that doesn't see them on a regular basis. So that might get that, that ball rolling there to check out the more symptoms of concussion. So we at the Brain Injury Association a couple of years ago adopted the REAP, which stands for Remove, Reduce, Educate, Adjust, Accommodate, and PACE. And it's a concussion-based management program. And it's a protocol that every school can follow. It's been endorsed by just about every pertinent affiliation in the state, from the Interscholastic League to DOH to RIDE, all of the school nurses, the school athletic trainers, the school counselors. And what it does is it's a manual. This is just the front page, so you know. They have it separated into teams: the family team, the school physical team, the school academic team, and the school medical team. So it's about 20 pages long. And so this could be given to any parent, any doctor, any school where they're interfacing with students that have concussion, and they can follow protocols. So we're all on one page. So we're all supporting the student in various ways. We also have this thing, I manage the Rhode Island TACT subscription. TACT is the Teacher Acute Concussion Tool. So if their teachers will get in touch with me, I can, you know, put in, they have a code. They put in a code and they'll get tip sheets on what to do and what accommodations to make in the classroom for initially, and then the next 3 weeks. So 4 weeks of tip sheets that come right into their email box on what they can do with students that are returning to the classroom after concussion. So we've really worked hard on this for the past couple of years. Now we just have to get everything implemented. So let's go, before we, you know, we're going to transition here. Let's just do I know you know most of the stuff already, but we're just going to do a little bit of brain injury 101 to kind of transition to thinking about what is brain injury and how it can affect the people with whom you interface. So why is it important for first responders to have a working knowledge of brain injury? Recognizing the symptoms and signs of brain injury when people are experiencing crisis in the community, and in interacting with them in an informed way can reduce escalation of crisis situations and improve engagement with the community. A brain injury is not something that happens before birth. It's not an individual living with intellectual or developmental delays, and it's not dementia, because they can't hold on to new information. But what it is, brain injury itself occurs after birth, can happen anytime in life. A survivor can learn new information and skills if repeated and given lots of opportunities to practice. So there is a chance to improve after a brain injury. I am, firsthand knowledge of that because I had a brain injury myself. And it's for individuals and families. They all say that there's a definite difference before and after a brain injury, especially something that's more moderate or severe. And this is all come from the NASHIA, which is the National Administration of State Health Head Injury Association. Great resource if you ever want to look up things from NASHIA. So when you look at the pictures here, I'm gonna move myself again. So who here has a brain injury? So what you might do is take the obvious, take someone who has a scar in their face, or scar on their head. And that's also a very good thing to know when you come across an emergency situation. But a brain injury has many faces. Any of these people here can have a brain injury. I have people come up to me and say, I've gone to support group meetings and help facilitate them. And they're like, you don't look like you have a brain injury. And I'm like, okay, what does that look like? Every situation is individual and different. Some people, it might be very obvious, but to some people, you can't tell at all. So when we talk about brain injury, a lot of words get thrown around, acquired brain injury and traumatic brain injury, and what's the difference? So an acquired brain injury covers all the insults to the brain that happen after birth that are not hereditary, not congenital, and not degenerative. So that includes both non-traumatic and traumatic brain injury, where traumatic brain injury, it's kind of like underneath that umbrella, is a particular type of acquired brain injury. It's just the way it's acquired. It's from a result of an external blow or force to the head. And it can result in either a TBI could be a open head injury or a closed head injury. Concussion's the closed head injury. And regardless of the causes of the brain injury, some of the consequences can be very similar and interventions may be the same. So for those of you who like charts, I'm kind of a chart person. You can kind of see acquired brain injury, non-traumatic, traumatic brain injury, and then traumatic brain injury could be opened or closed. A concussion, which is a mild TBI, would be the closed. But even things like, gunshot wounds would fall into the open head injury. A lot of times, you can get a TBI from a exposure or a blast. Most often closed. When they are open, it's usually very traumatic and often deadly. So another look at it here, when you look at ABI, the acquired brain injury, that could be tumors, disease, infection, toxins, including chemicals, drugs, and alcohol, stroke, lack of oxygen, anoxia, and hypoxia. There could be a cardiac event, a near drowning, choking, overdoses, and then subset of traumatic brain injury, which could be open head injury for moderate severe, or closed, which would be a concussion or a mild traumatic brain injury. So I always like to tell students when I go in and talk to kids, your skull is like a helmet for your head. It's protecting that gelatinous jello brain inside. You have all of your dura mater, kind of like that cushioning. That's your styrofoam inside of like your helmet, your bike helmet. And then there's that cerebral fluid that's floating around there. And your brain is up against it. When you're older, your brain shrinks, so there's even more chance of getting a concussion because there's more movement there. But this is what I call the helmet. Your skull is helmet for your brain. So when we look at concussion itself, we look at the insult of concussion. We look at the mechanisms, the impact and the recoil and things that can happen inside the brain. And when you look at things right here, because we have these bony protrusions in the lower left-hand side, yes, a lot of things happen with the frontal lobe or on the side, but they can also be bumping up against these protrusions and cause some kind of insult inside the brain as well. Just some words here, the acceleration, de-acceleration, an object in motion stays in motion until it's acted upon. So it strikes the skull. A coup and counter coup. So if a coup happens, the contusion or the brain injury happens right beneath the impact. Counter coup happens on the opposite side. I myself was hit on my bicycle over 25 years ago, but I hit on the right-hand side here and my brain bounced up on the left-hand side and did some damage to the occipital lobe on the left-hand side. So I had a counter coup. And so that sudden rotation and stretching of brain structures result in tearing and shearing of the nerve fibers, the axons. There's that myelin sheath that covers the neuron, and that could be impacted and broken apart with that twisting. And then chemicals that are inside get out and out go inside. So we call it an energy crisis because your brain is all of a sudden going, okay, we have to stop this. And then all of a sudden there's energy and there's energy being released. So you kind of like having your plug pulled out, like, whoo, where everything kind of slows down. So there are the lobes of the brain. The frontal lobe, major real estate here, thinking, memory. I always tell kids, this is your command center where everything gets done. So unfortunately, a lot of impact happens there too when you get a concussion. Temporal lobe, hearing and feeling and thinking. On the side, you can actually feel right here how soft that is, around right before the temporal lobe. Brainstem, bodily functions, occipital lobe, like me with my eyesight. So what happened with my particular injury is I had like a sunspot in front of me where I couldn't see from that spot. Some people lose a hemisphere. I was very lucky, but it wasn't exactly, I had 20/10 vision at the time. So it wasn't my eyes that weren't doing it. It was the little spot right here that was not computing and not processing that information at a certain location, just right of center for me. And then of course, they always look at the emotional part here. That's, I don't know if you know Phineas Gage, the story of Phineas Gage, where they had a rod, this is back in the late 1800s, went through his head. But one of the things that they noticed, it's one of the earliest recordings of someone who had a big emotional and behavioral change after a brain injury. So kind of like wrapping this section up, a TBI may lead to a longer or short-term health, oops, sorry about that. A longer or short-term health problems, depending on the severity, how long it lasts, but each one is unique. We always use the analogies of it's like a fingerprint or a snowflake, because each is unique in its symptoms, experience, outcomes, severity, the length of time. A person with a mild concussion may have just a short-term 2 to 4 weeks and they're okay. And then someone with a moderate severe could have more long-term or lifelong effects from their injury. So when you look at the traumatic brain injury, when we talk specifically about the traumatic brain injury, mild, moderate, and severe are the 3 categories. And that depends on the severity, but loss of consciousness or amnesia. But around, this is approximate, 80% are mild TBIs or concussions, 10 to 13% are moderate, 7 to 13% can be severe, or are severe statistically. So we already know the definition of a brain injury and a concussion. So sometimes it has that little M to stand for mild, when it moves rapidly back and forth, but the sudden movement that causes the brain to bounce or twist around in a skull, creating chemical changes in the brain and sometimes stretching and damaging the neurons, the brain cells. So analogies we use, it's not really a hardware problem, but a software problem. We also say sometimes it's like having a small car, in a small gas tank, that once you have a concussion, you need to recharge and refuel more often. Or it's like having an iPhone 6 instead of an iPhone 12, where, you just have to chug along or have to get a lot of updates. So although they used to say, close yourself up in a dark room and not do anything, we find that that's not the case anymore. Rest is still important because it might be very disruptive to your sleep. But you want to get people back into a routine of a regular sleep routine as well. But they are going to need some time, and there's no fast and fixed rule on how long it's going to take. It's just going to take as long as it takes, because they say once you see one brain injury, that's what you've seen, one brain injury. So there's been a lot of newsworthy comments about subconcussive events. The jury's still out, they're still studying that, mostly in youth, really young youth, like pee-wee football, that, if you have like subconcussive events, they're not concussions, but over time, if you continue to get these subconcussive events, you could also have some axonal damage to your brain. We mentioned before, second impact syndrome. That's getting a concussion while you're recovering from the first one. So you're having that cascade of metabolic events that could really be more serious damage or death. Post-concussive syndrome, sometimes it's kind of like long COVID, post-concussive syndrome is when it persists beyond that normal, 2, 4, 6 weeks, and you're having symptoms way beyond. And that's from the Concussion Legacy Foundation. If you don't know, they're the ones that have that brain bank up in Boston. It's the largest brain bank of the world. And it's where they have the majority of the NFL players that, or who themselves or their families say that they're having issues with CTE, or they think they're having issues with CTE. They donate their brains because you can only see post-mortem how affected they are. And at last that I checked, it's well over, it's like 95% of the people who knew something was wrong actually had CTE. Another thing I wanted to mention too, if you have anything, if a person already has a history of migraines, learning disabilities, ADHD, mental health concerns, anxiety, depression, juvenile justice, overall population, suicidality, brain injury will exacerbate this. It's interesting, that as far as that suicide rate, it is like about double or 2 times, although it's still a small percentage. They do find like either 1.5 up to 3%. It is double the suicide rate for people who have brain injury and complete, have brain injury and actually complete suicide or have suicidal ideation. Although it's small, it is still double. So they're looking at that trend as well. There's a lot of really new studies out and meta-analysis on all of this. So I have to continuously change my my presentations because as more information comes in. So when you start talking about moderate to severe TBIs, they can be much more serious and costly. It includes a longer loss of consciousness or amnesia, can lead to some long-term or lifelong health problems that may affect all aspects of a person's life and their family's life, because sometimes all of a sudden someone becomes a caretaker. It's not just the financial, like losing a parent's income, but having to take care of that person as well. So they may need some ongoing medical care. It impacts the life of every individual, their family. It has a lot larger societal and economic toll. That shows right here that indirect and direct costs were estimated to be approximately $76.5 billion in 2010. So extrapolate that to 2022. The cost of fatal TBIs and TBIs requiring hospitalization account for approximately 90% of total TBI medical costs. So when you look at things here, you look at the potential effects of the TBI. It affects your thinking and learning, your motor skills, hearing and vision, emotions and moods, and also behavior. So like we said before, every brain injury is unique. They can be very different from person to person. And most people will have one or more health problems after the injury that include physical symptoms or any of these symptoms here. So that could be difficulty, cognitively thinking and understanding, problem solving, concentration, difficult remembering, the motor skills, weakness, coordination and balance, vision, moods and behavior together. There's a lot of sleep issues as well, which will also affect this. Feeling more emotional than usual, nervousness, anxiety, anger, quick to anger, like not a lot of filtering, trouble controlling behavior and personality changes, and impulsivity. So when you look at the moderate and severe, this is from the CDC just recently, 22% of people with the moderate and severes died, 30% became worse, 22% stayed home after their moderate to severe brain injury, and 26% improved. So that's a very low improvement rate. So we want to avoid these at all costs. Long-term negative effects of TBI are pretty significant. Even after surviving a moderate or severe TBI and receiving inpatient rehabilitation services, a person's life expectancy is 9 years shorter. And TBI increases the risk of dying from several causes compared to people without TBI. People with TBI are more likely to die from seizures, drug poisoning, infections, and pneumonia. As you can see, the seizures is a 50% increase, 50 more likely. So after inpatient rehabilitation, what groups are more likely to die sooner? Unemployed, older adults, people with fall-related TBIs, because they usually have some other issues besides the TBI that it affects, people who are not married, men more than women, people with more severe TBI, and people with fewer years of education. So among those still alive after 5 years after injury, 57% are moderately or severely disabled, 55% don't have a job, 50% return to the hospital at least once. 33% rely on others for help with everyday activities. 29% are not satisfied with life, reportedly. 29% use illicit drugs and misuse alcohol because they're really trying to numb what's happened to them. 12% reside in nursing homes or other institutions. And we know that also that there's also a very high divorce rate after a severe and traumatic brain injury because of those changes that happen. So the new normal, for whatever reason, doesn't work out with the relationship. It's very sad, actually. So how may all of this relate to you or affect your job? So locally, the Rhode Island Traumatic Brain Injury State Action Plan for 2019 to 2021, and it's also happened for the next action plan. The first recommendation is to increase TBI education and training opportunities for Rhode Island in the emergency medical service professionals, first responders, emergency department personnel, nurses, healthcare providers, law enforcement officers, interpreters, translators for both the medical and court. So we want to make sure that we're spreading more awareness, we're getting more information out there, and we're helping you. I just did I did something with the police academy as well. So we have presentations with them. How do we help you deal better with these crisis situations involving traumatic brain injury? So the Rhode Island TBI Registry has been around since 2007. The Rhode Island law mandates a traumatic brain injury registry of traumatic brain injuries diagnosed in the emergency department or in inpatient units. Hospitals are mandated to provide information to the DOH on all individuals with brain injuries within 14 days of diagnosis. So an analysis of the registry data allows staff to pinpoint where and how injuries are occurred, what ages are affected, and enables the development of programs to prevent injuries. You know, it's taken a little bit of a time, you know, and we're working on it even more, but it's really, really important because what happens is people go into the emergency department and it might not be your, you know, like your first impression or second impression, and they're trying to maybe after an accident, stop the bleeding. So sometimes, you know, that TBI information may not get into the registry. So we're really trying to make, or the Department of Health is really trying to make a concerted effort to make sure that this registry information gets recorded, so we have more information to get more support for everyone involved. So when you look at this TBI registration form, they use the medical codes there, most frequently used medical codes. They're very similar to the ones that you use. Fractured skull, fractures or other specified skull, facial bones, injury to optic tract, intracranial injury, crushing, Shanken infant syndrome. So it's important that we report as accurately as possible. So let's look at some stats specifically related to the Rhode Island EMS from the Department of Health Centers for Emergency Medical Services. They created a report just for me. So this is hot off the statistical track here. So the Division of Preparedness, Infectious Disease, Emergency Medical Services, this is what they have to offer. So the Rhode Island EMS stats show here, this is directly from your state data system. The timeline, you can see from 2018 to 2021, we're getting these increases in calls. Maybe not between 2019 and 2020, it's a slight increase, but the calls are increasing for traumatic brain injury. So overwhelming majority of patients are treated, 93%, and transported by the EMS, which is 90%, after a TBI related call. Only 6% were not treated and 8% were not transported. This does not include patients for whom treatment or transportation was not required, including those who were dead on scene. This demographic information I thought was interesting too. The top one has the breakdown between females and males, and you can see them kind of evenly portioned. As they get older, though, things tend to change just a little bit. So, you know, that 48% versus 51, now all of a sudden, looking at patients 69 or below, males make up the larger portion. However, when you look at the patients 70 and older, that flips to women who are disproportionately affected. So over 27% of all female patients were 70 plus years older compared to 16% of male patients. And on the bottom here, when you look at the overall, nearly 1 in 3 calls with a TBI impression was for a patient of 80 years or older, for obvious reasons. So when you look at the statistics, I always show statistics, you know, when I go to schools, there's like a spike between like the 14 to 25-year-olds, you know, for obvious reasons, you know, behaviorally. And then all of a sudden it spikes up again when you hit 75 and older for mostly falls. Co-occurring syndromes due to the age distribution presented, coupled with falls. The top 5 most commonly classified syndromes for TBI calls were as follows: fall from the ground, that's almost 9,000, alcohol, motor vehicle crash, non-severe, fall from height, and mental health. So a total of 6,267 patients were transported to level 1 trauma facilities, being Rhode Island Hospital or Hasbro. The majority being Rhode Island Hospital, 88% with adults, and then 12% to Hasbro. So this is from your state, Rhode Island State Emergency Medical Services Protocol. We don't comment a lot on medical things because we're not a medical facility at the Brain Injury Association of Rhode Island. What we do is we interface between people who have brain injury and the supports they have from medical. But I just wanted to point out a couple of things that are in your emergency protocols. So you have obviously head trauma, traumatic brain injury in section 4. A history or clinical evidence of blunt or penetrating head trauma, a patient with anticoagulant or antiplatelet with a fall. So you have your routine care, you obtain a baseline neurological exam. If patients are clinical evidence of increased intracranial pressure, managed per the acute neurologic event, that section with evidence of increased ICP protocol. So provide airway management as indicated per age appropriate to the airway management protocol that you have. Ventilate the patient as indicated and maintain the stats right there. Avoid hyperventilation. Ventilate if patient has a rate of 8 to 10 BPMs. If a patient has an altered mental status, perform a glucose analysis and manage per age appropriate. And then there's a section that, that links to diabetic emergency protocol. Transport to the nearest appropriate hospital emergency room. Patients with evidence of TBI should be transported to a specialty hospital, being Hasbro or the trauma care. So the better we look at this and make sure that that gets into your information that you're transferring to the emergency department, the better off everyone is. So when you look here, the pearls of wisdom here, patients taking anticoagulant, antiplatelet agents with altered mental status should be transported level 1 trauma. Follow and document the patient's neurologic exam, convey the patient's best neurologic examination and any episodes of hypoxia or hypotension during the patient handoff. Hypotension is usually a terminal event in isolated head traumas. If hypotension is present, the etiology should aggressively, identified and treated. Serial examination of patient's mental status should be conducted and documented. Attempt to obtain related use of antiplatelets or coagulants, sorry, I'm speaking too quickly, by the patient. Ischemia is worsened with over-aggressive hyperventilation. Patients without evidence of increased ICP should be ventilated to maintain normocapnia. Short isolated episodes of hypoxia or hypotension should be avoided as they can cause a secondary brain injury. and hyperglycemia is associated or worsened with worsened neurological outcome. Glucose-containing solutions should be administered only as indicated for the treatment of hypoglycemia. So there's a lot of things that happen because there's so much chemical actions that are happening in the brain, and now they're being interrupted with a brain injury. So how do you, the EMS, document TBI on calls? So where the TBI registry and that's happening at the hospitals are 6, you have 11. So yours are much, there are 5 more and they're much more specific. And even though it might not be your first impression, it could be your second impression, but if there's something that happens on your paperwork that during the handoff, it'll be followed up better and we can get better data from the emergency room. So it shows here, so there's their form on top, and then there's the Rhode Island EMS form on the bottom. Give you a moment to look at that. These are examples of concussion evaluations from the CDC. So they're kind of like a smaller version. I don't have what is actually being used by the emergency departments presently, but I'd like to get that up there. And if I can get my hands on that, I can share that with you as well. You probably have more of a chance of seeing that than I. But there are forms available. So how can you play a role? So if you encountered a traumatic brain injury, just be as specific and accurate as possible with your reporting. So better reporting has, gets more reliable data, gets into the system, and with better supports, we get optimal outcomes, and we can also show more of a need. So that also usually relates to money down the road, whether it be grants or more systems analysis. The better we get, the better we're able to treat, and the more supports that we can probably get into our state. So the good news is TBI is on the radar both locally, with the TBI registry, and nationally. So I'm happy to report in just the past 2 months, I've had to change the dates on this 3 times, which is a good thing because there's been movement in the HR 2992 TBI and PTSD Law Enforcement Training Act. So it was introduced May of last year. It went through the House of Representatives just a couple of weeks, last month, because this is happening in June. And now it's passed in June to the Senate. So it says it requires, this is from the Bureau of Justice. The bill requires to consult with relevant agencies to establish crisis intervention training tools for first responders to address individuals with traumatic brain injuries, acquired brain injuries, and post-traumatic stress disorder. So this is very good for us. That it's to ensure that at least one police department designated one police department designated as a law enforcement mental health learning site utilizes tools that such tools are part of the police mental health collaboration toolkit. So when you look at crisis intervention training, that's a lot with mental health right now. What's going to be added to that mental health is TBI and PTSD. So the bill requires the CDC to study and report the prevalence and incidence of concussion among first responders and the creation of a TBI PTSD training for first responders course. So it would implement several measures to better train law enforcement first responders for interactions with individuals suffering from traumatic brain injury and PTSD. So they can be difficult to identify, as we all know. We're going to talk about that a little bit right after this. We need for first responders to be better prepared to de-escalate any inappropriate behaviors or other issues and able to refer them to professionals for help. So it's much more of a collaborative effect with the mental health system as well as in one group with the trying to reduce recidivism back into the prisons as well. So it'll provide those who protect the communities and crisis intervention tools. They give them the tools that they need to when they encounter someone in a domestic or a civil dispute who suffers from PTSD or a TBI. So it's a bipartisan legislation. It's actually seeing some movement now. So we're very happy to see, and we're looking forward to, and we will happy to announce when this actually goes through. So what common challenges after brain injury that might be observed by first responders? So they kind of fall into three groups: that cognitive thinking with memory and attention, comprehension of what's being read or heard. So if you're going through and you're reading something or you're talking to people, that comprehension might not, even though they might look like they've been paying attention, that might not be getting through. So they might have difficulty communicating their thoughts, like verbally or in writing. Problem-solving difficulties, impulse control, difficulty organizing thoughts or words or actions. That's executive skills. Emotionally, there might be some depression and anxiety, reduced or lack of awareness of functional impact of the injury, disinhibition, impulsivities, reduced frustration tolerance. So they might be, get frustrated very quickly and irritable. When you look at them, they may have a poor coordination or an unsteady gait, slowed or slurred speech. I work with the police department to say, when you see slurred speech, they automatically think that it's alcohol or drug intoxication. But how do you tease that out between one and the other? A slow, slurred speech might be someone who has a brain injury or alcohol intoxication. But that coordination, usually someone who has a lack of coordination, that lack of coordination, say if they walk kind of funny, will be consistent, where someone who's drunk will be like uncoordinated, get it back again, and then be uncoordinated again. So that's, it's a little up and down. It's very difficult to determine. Sensitivity to light and noise, and then that neurofatigue. So you might notice this right off the bat when you come across a person that has a traumatic brain injury. So here, there's some tools to promote these positive interactions with individuals with brain injury. There's awareness, patience, and simplicity. We're going to break those down. And then there's elements of communication we're going to talk about first, what words and tone of voice and body language that you can use to maybe de-escalate a situation because this person has this heightened awareness, and they might be very agitated, more so than the regular person, the person without a traumatic brain injury, when you come across a crisis situation. So let's take a look at it. So when you look at the elements of communication, your physical body language is the majority of it right there. And then the words are smaller, and then the voice and tone. So if you're very physical and the tone of voice is a little bit more aggressive or loud, those people that's going to exacerbate the symptoms that they're already having. So when you may, what you may encounter when a person has or had, so either a present brain injury that just happened or a person that has a previous brain injury, you come to a situation, they might be really confused and scared. They suffer from PTA, which is post-traumatic amnesia. So they may be awake and they may be talking, but in a very uncharacteristic manner. When I had my bike accident and I had a traumatic brain injury, I don't remember anything, but apparently I talked to people. I told them to call people. I have no recollection of that at all. I just remember that evening waking up in the hospital. So I can say firsthand that there is some kind of post-traumatic amnesia that goes on. They're usually people who live by a routine. So brain injury survivors, one of the things that they do is they like this routine, and they tend to do things. Sometimes they can get very rigid in that way, but when their routine is upset, that really throws them off. So they could be very bothered by the noise and the distraction and the commotion of the scene. So it's right off the bat, it's good to just kind of like slow down and explain. If you notice some things, you can ask if they have, if you're asking if they've ever had other health complications, brain injury might be one of those questions. Different states have toyed with putting something on their license, and we don't have anything like that, but we at the Brain Injury Association will give out a little card that says, I have a brain injury, so that people can take it if they, they want, the people that we know, the survivors that with whom we interact, and they have that so they can take it out to show somebody. So there's not any incidents where, as far as with the police, they think people are being disrespectful and combatant, that there might be if they're showing some kind of behavior issues. So cues that you can more easily observe that may indicate a person that has, a history of brain injury: scars, like we mentioned earlier in those pictures. If they have some scars on their head or their neck and their forehead, you might want to say, oh, wow, like, how'd you get that scar? It could be just part of the conversation. An unsteady on their feet, if they limp or drag a foot when they're walking. Maybe, a little easier to see is if they have a cane or a walker or a wheelchair. An eye patch might be an indication. They have these diamond cut lenses on one side of the glasses sometimes, with some people who've had brain injury. So cues that may indicate, continuing, these might not be as obvious. Maybe living with a history of brain injury, they have difficulty making eye contact. Now, a lot of times, especially in a police situations, if the people aren't making eye contact, that usually cues the police officers think, okay, what's going on with this guy or this person? They seem shady, or they're not, what are they giving me? But that can sometimes really happen. Sometimes you see nystagmus, where their eyes, move around. Difficulty making eye contacts, looks like they're not paying attention, which sometimes to some people will translate they don't care, or they're trying to avoid. With a brain injury person, they might not even realize that they're doing it, or might be able to do it. They might have that blank facial expression in response to your question or your request. Seems unable to relay basic personal information. They might be having some processing here. That could even be with, speaking or aphasia. Responses are disorganized, verbally or in writing, or the responses may include information that was not requested. So they might go off, you might have to redirect. I mentioned redirection several times in the next few slides. So you have to repeat questions, or they might have to repeat responses. Responses are not factual given the known facts. There's this thing called confabulation, where sometimes people with brain injuries, their brain creates some stories or unfactual information to fill in the gaps, unbeknownst to them. I've seen this happen. I've seen it on videos and stuff, working with the Brain Injury Association. And there was one person that, thought that they had like a family in a place that they didn't even have a family. And then here was her husband going, okay, now, that's not true, because she had herself married with a family somewhere else. So I've seen some video on confabulation. It's fascinating and very interesting, but that can happen. They might deny that there's problems or challenges, that are very clear to others. There might be some disinhibition and impulsivity. Sometimes people make up these stories, and they might be a little bit defensive because they don't want to seem stupid. They will just give you information that's not true, or deny that there's a problem at all, while others are much more upfront. Again, it can run the gamut, once from the scale from one end to the other. So here are some crisis management techniques and de-escalation techniques from the Brain Injury Association of North Carolina. There's, I think Virginia has one. It started with crisis intervention training with Memphis, because there was a police shooting of someone with mental health. It goes back years, but this has been evolving. And the North Carolina one has the premier one in the country right now. Everyone bases their models on there. So here's some tools for first responders to promote some positive interactions with individuals with brain injury. So let's start off with awareness. Observe for those outward signs of brain injuries, the ones that are obvious: scars, maybe there's medication, ambulatory devices. Slow down and speak softly in short, simple sentences if needed. Be non-aggressive. I'd never speak to someone with a brain injury at the pace that I'm speaking to you for a presentation. So I have to slow down, maybe, so they have a little bit more processing time. So use some mental grounding techniques to help with orientation at time and place, assist them with memory and confusion. That redirection that I mentioned before is the golden ticket, because some people go off. They might be repeating themselves. They might go off into a different direction when you have to say, come, let's go back to what we were talking about. So they might need some redirection. And even if you have to like ask first, but let's touch them, like, may I touch your shoulder? Let's come over here and let's go back to this. It could be a very simple technique to bring them back to the matter at hand, whether you're gathering information or trying to assist them in any way. But be very mindful of conditions that might mask brain injury symptoms. Sometimes people can get focused with mental health, or there's a domestic violence situation or substance abuse. So those might be ones that people focus on first and not the traumatic brain injury. And then when you look at, like, for instance, someone in a domestic violence situation, they might not be able to, because of repeated brain injury, they might not be able to follow along with the questions. And then once, if they're seeking help, they might not be able to have that follow through because something cognitively is wrong with them, and they really have to work on follow through as far as following through on support systems. Personal movements, so moving around, a location in relation to the individual. There's some issues with space, sometimes. Don't get any closer than necessary. Remain aware of any weapons or personal gestures that you have. Ignore the negative and use positive prompting. So sometimes it's hard to ignore the negative, but you can turn around and say something like, thank you for sitting down with me like this and really going through it. Or, thank you for coming over here so we can get away from that commotion. So if they do something in a positive manner, just that positive reinforcement will calm them down. Patience, yes. Stay calm, even if the behavior escalates. What happens in a crisis situation is, whether it's police, EMS, first responders, anyone's on the scene is like, go, go, go. We have to do all these different things. And it's kind of counterintuitive to slow down because you're multitasking. But even on the outside, if you're multitasking in your brain, try to stay calm and slow things down, even if the behavior is escalating, because that will help bring it down. Emphasize that I'm here to help. You can suggest deep breaths instead of like, calm down, like, okay, let's take a few deep breaths. Let's move to the side, maybe. Let's sit down over here. Let's go over this again. They might even need a little bit of a brain break. You might have to do a little bit, if it's appropriate to the situation. They might need to do a little bit and then stop for a little bit and then do some breathing and then go back to asking some questions. So you use those active listening strategies. You could paraphrase. So are you saying this? Or clarify, or do some perception checking. You can use phrases like, well, it sounds like this, and this is what I'm hearing. Just kind of like check in. Is this what you really mean? Or you can do more of the questioning to get clarification from someone who's not being as clear as, or giving you all the information that you need. So I mentioned before, allow for a response time to process. It might take like 3 or 5 seconds. And that pause, even though people are in a hurry to get things all wrapped up, hurrying is not going to help a person who's really trying to retrieve and process. Redirect or refocus is necessary, but concrete short answers may be given if there's difficulty with speaking or understanding. Sometimes there are people that come up, they go, I always say they go to the right filing cabinet, but they go to the wrong file. So they could be saying a word that's like similar, but it's not exactly the word that they're trying to say. So sometimes you have to do some problem solving yourself and questioning to find that out. Sometimes yes or no questions will work rather than the open-ended. Other times, it's very situational. Other times, if you're asking someone to explain, they might be explaining what happened, but you might have to keep them on track. But what's important to know really is, the brain injury survivors may be trying their best to respond, but they just can't take what they know and apply it as effectively as they could before their brain injury. So they get very frustrated too. So, they're good intentions most of the time, but they're having cognitive challenges. Don't rush, don't speak over or become frustrated or talk down to somebody. I already mentioned the 3 to 5 seconds for a response. Incorporate frequent short breaks if there is some neurofatigue or physical cognitive fatigue. Redirect as necessary, I mentioned. Concrete and short answers may be given if there's difficulty with language comprehension. Difficulty with short-term memory may take recalling an event or piecing together a timeline difficult. So just knowing that makes things easier with your patients. You can involve others. If there's a crisis situation and there's family or friends or bystanders, the family and friends would know more personal information, but you can also, about maybe previous hospitalizations or diagnoses, you can try to get some more information from other people around the brain injured person. Simplicity. One person speaking at a time, obtaining and maintaining eye contact. Even if they're not doing eye contact with you, they know that cue. Most people know that cue, that eye contact knows that you're paying attention to them. So say the person's name often, speak slowly, neutral tone, enunciate words, avoid speaking down or not at an appropriate age level, like I had mentioned. Keep instructions very simple. One-step questions and instructions work well, one step at a time. Have a person repeat directions or instructions. In their words, to provide choices when there's this cognitive flooding that happens. It kind of just jams up their brain and they can't get their information out and communicate. Reduce further triggers or distractions, noises, televisions, another person talking or yelling, flashlights. If there's a quiet area and that's appropriate, move to a quiet area. So what does the Brain Injury Association do? We are there for survivors, caretakers, and their families. Aside from what we do with education and advocacy, we have support groups for people who have sustained a brain injury, survivors, education, advocacy, resources, and we have navigator services. The most frustrating thing people have sometimes, they have a brain injury and they're trying to figure out how to work the systems in the state. Unless they have an advocate, it's challenging at best. Never mind when you have a brain injury. So we offer navigation services to individuals diagnosed with brain injury to help them and their families with the personal supports. So the navigator position is made possible through the Rhode Island Department of Health, and it promotes access between individuals and their support network and appropriate community-based resources to provide information, education, services, and supports to make informed choices. It is an investment in positive change and improved outcomes and decreased dependence on the system. So it's very individualized. The brain injury navigation is effective and valued. It's participant driven. It is creative and flexible and helps build community, the community partners around. So there's usually a plan, and then Colleen McCarthy is our brain injury navigator presently, and she helps people get to the right support systems that they need. So they include identifying and locating resources, services, and supports, educating the community and personal support systems to understand the barriers and how it impacts individuals with brain injury. So we talk to you, we talk to the police, we talk with hospitals, rehab centers, the ERs, a variety of people, all trying to get people on the same page so we can best help support, which turns into the better outcomes for individuals with brain injury. So facilitating access through the development referral system of resources, services. We try to assist individuals to advocate for themselves. So there's the independence there. Support medical providers by providing the tools and resources to help their patients. Provide individual and service providers with a customized packets of materials. And we do a lot of data collection because we're trying to look at the trends and the gaps and the barriers that are happening in Rhode Island presently. So, let us be of service to you. One of the things that I didn't, mention too, I always mention at the end that anyone can have a brain injury, including first responders. They have a higher incidence of brain injury for obvious reasons, because they come in contact with crisis situations. So whether it be yourself, whether it be patients, whether it be someone that the doctors, you can always give referrals. You can tell someone who's going off to the ER, there is a brain injury association that you can contact with help. We're also working with the ERs so they can refer people to the Brain Injury Association. But it could also be a reference to someone that a friend, a family member, someone that has a child that there's a child that has to go back into school can call me, and I can interface with the school to make sure that there's a better transition and people get the supports that they need. So the Brain Injury Association of Rhode Island is here for you to answer any questions, to educate, to spread awareness, make referrals, and provide support all around. So you can find us at BIARI.org. My email address is on there. Colleen McCarthy is our brain injury navigator, and you can always get in touch with us through the office. And we're happy to come to anyone's place of work and repeat this or give you a presentation to fit your needs individually. So all of the information is here. They're on the resource page. I try to provide links because I know this is being done recording, and so you can access the links automatically. And if there are any questions, feel free to contact us. We're happy to answer your questions. If you want more information, we have resources that we can bring to your firehouse or wherever you are, or we bring them to doctors' offices and schools. So we're really trying to get that brain injury community of support for the people in Rhode Island that sustain a brain injury. So I hope this was helpful to you. I know there's a lot of information here. Feel free to go back and watch it again. But thank you for your attention on this very important topic. And we certainly appreciate your participation in this presentation. Take care. Be safe. Bye-bye.